Hello, everyone. Welcome to the Organizational Ethics Consortium at the Harvard Center for Bioethics. I'm Charlotte Harrison. I co-chair the consortium along with Kelsey Berry. Today, we're here to talk about health justice. In particular, we'll look at efforts to promote health equity by integrating medical and social care, as many healthcare organizations are spending significant funds to try to do. What makes sense in terms of goals and responsibilities for these organizations in seeking to do this work? And how can we best understand effectiveness for these efforts? What are some key choices facing organizations in this space? And what are the implications of choosing one path or another? Today, we have an outstanding panel of experts who can share with us their extensive research on this topic, as well as their daily experience with patients, communities, and healthcare organizations. Next slide, please. Before introducing the panel members individually, I'd like to share a quick introduction to this consortium overall. We operate in parallel with other center consortia series on ethics in clinical medicine, health research, biotechnology, and health policy. As an organizational ethics forum, we focus primarily on healthcare provider organizations, but our programs have also explored the concerns and experience of professional medical societies, health plans, biotech companies, and independent research organizations. What are the roles of these organizations in the culture and political economy of today? Presenters discuss key ethical challenges and what has been learned in responding to those challenges. You'll see on this slide the topic of our own April program, along with ways you can be informed of upcoming programs in any of the consortia. Next slide, please. Today, as an audience member, you have two ways to participate. One, you can use the chat box to share your thoughts or questions at any time. Also, at several points in the panel discussion, there will be a Q&A period when you can use the hand raise function to signal that you'd like to share your question orally. Next slide, please. Now it's my pleasure to introduce today's panel. Opening the panel will be Dr. Monica Peak. She is the L&H Block Professor of Health Justice in the section of General Internal Medicine and Associate Vice Chair for Research Faculty Development, both in the Department of Medicine at the University of Chicago. She's also Associate Director of the Chicago Center for Diabetes Translation Research, Director of Research, and an Associate Director of the McLean Center for Clinical Medical Ethics, and Executive Medical Director of Community Health Innovation. Next slide, please. Also presenting is Dr. Marshall Chin. He is the Richard Perillo Family Distinguished Service Professor of Healthcare Ethics in the Department of Medicine at the University of Chicago. He's also an Associate Director of the McLean Center for Clinical Medical Ethics. He's the co-director of the Robert Wood Johnson Foundation's National Program Office for Advancing Health Equity, Leading Care, Payment, and Systems Transformation. He's also co-chair of the Health Equity Advisory Team for the CMS Healthcare Payment Learning and Action Network. Next slide, please. Our third presenter is Dr. Laura Gottlieb. She is the co-director of the Social Interventions Research and Evaluation Network, which many of you will know as SIREN. She's also a professor in the Department of Family and Community Medicine at the University of California, San Francisco. Next slide, please. Our final panelist is Dr. Lauren Taylor. She will moderate today's discussion among the presenters. Lauren is an assistant professor in the Department of Population Health at NYU Grossman School of Medicine, where she's jointly appointed in the Division of Healthcare Delivery Science and the Division of Medical Ethics. As many of you will know from Lauren's prior appearances at this consortium, her scholarship often focuses on organizational ethics. Her work is informed by her PhD from the Harvard Business School, her master's from Harvard Divinity School, and master's from Yale School of Public Health. Final slide, please. Finally, we'd like to acknowledge and thank the organizations that have co-sponsored this event with the Harvard Center for Bioethics. both Siren and the McLean Center for Clinical Medical Ethics. And with that, we turn to Dr. Peak.
Great. Thank you so much. I want to just begin. I'm going to have a few sort of level setting slides to start our conversation today about the organizational dilemmas in integrating medical and social care to improve health equity. And first, I just want to start with a definition of health equity. One I like to use is that health equity exists when all people, regardless of race, sex, sexual orientation, disability, socioeconomic status, geography, location, or other societal constructs, have fair and just access, opportunity, and resources to achieve their highest potential health. And so none of that really mentioned medical care in that definition, because we know that much of health is driven by many factors outside of medical care and in health systems. But healthcare is an important component of that. And as we're thinking about the kinds of care that we want to deliver, we want that to be equitable as opposed to equal. And so this is a RWJ sort of infographic that many of you may have already seen as we're trying to think about narrative ways to have that conversation. We don't want everyone to have the same widget or the same bicycle, despite different kinds of circumstances and skills and needs that people have. We want to have a kind of system or tools or widgets or bicycles that fit the individual needs of patients and can get them to the finish line at the same time. So as I was mentioning, that it's not just healthcare that determines health. It's a lot of things outside of healthcare that are disproportionately or unequally distributed. So that kind of structural inequity is what we are increasingly trying to address when we think about health equity. And it can be at the patient level. So when we think about social determinants of health at the patient level, we often call those health-related social needs. And a shout out to Laura Gottlieb, as she's helped us think about a taxonomy of how we identify and have terms for all of these different things. So things like food insecurity, housing instability, health insurance, healthcare access, exposure to violence of many types. And so integrating medical care and social care is something that we're sort of on a path of discovery of trying to figure out how to best do. But doing so without having a health equity lens, in particular, a racial health equity lens, means that we are potentially not doing so with our full skill set that allows us to reach health equity. And so what might that mean? There are lots of different kinds of racism. These are three of the sort of most commonly thought about types: structural racism, differential access to goods, services, harms, and opportunity based on race; interpersonal racism, differential assumptions, prejudice, or actions, bias towards others according to their race; or internalized racism, and that's the acceptance by members of stigmatized races of the negative messages in society about their abilities or intrinsic worth. And so those different kinds of racism can intersect with interventions that are trying to bring social care to vulnerable populations. And so if we, sorry, one last slide. Think about how that might manifest. So if you think about structural racism and an effort to address housing insecurity or housing instability, and we think about the structural inequities around residential segregation, for example, then we might see, or we do see, that there are decreased resources in communities where people live. And so there might be an inequitable distribution or effectiveness in that program because of the structural inequity around race and residential segregation. Or for interpersonal racism, if people were trying to have a program that was doing a social service program or a support group or something like that for elder people for social isolation, let's say, people who were navigating those social services and resources may have additional barriers because the people who are delivering the program may have biases or may be acting in ways that have discrimination against certain groups of people. And then the last is the one we think probably least about, but has a lot of increasing salience as we think about chronic disease management and patient activation, is the internalized racism and how people may have less hope or less confidence in their ability to overcome barriers to engage in programs and activities. And so all of these may be at play that if we are not planning for equity, may result in the differential treatment impacts for programs. And so one of the things that I worked on with Laura was a systematic review looking at social care interventions to see how often this might have been happening. And so it's something that I'm happy to talk about in the course of our time together. But not today, but not right now in our opening session. The last is sort of thinking not just about the patients as they enter our healthcare system, but scrolling back and thinking about the larger community. And because that's actually where the structural inequities and policies are more commonly at play. And is there a role for health systems, healthcare institutions, as large anchor institutions addressing those larger issues, those not health-related social needs at the individual level, but the actual social drivers of health. And so many of you may have seen the New England Journal of Medicine article written by David Ansel and others about the anchor strategy, which is one that has been adopted by Rush University and many other hospitals and health systems around the country, which is a place-based business approach for health equity, which involves building community health and wealth by means of local hiring, investing, purchasing, and community engagement. And so that's another thing that I'm just sort of putting out there for conversation as to sort of level set how we're sort of talking about these issues. And for that, I'll hand it over to Lauren.
Thanks, Monica. Okay, team, this is so fun for us to all be here together. Happy Good Friday, to the extent that that's a phrase we can use. I'm really pleased to see almost 70 of us here on the line. I'm going to give you kind of the run of show here as the moderator, and then I'm going to try and keep us sort of moving on time, although I anticipate with this group it may be a challenge. The goal here is to take on two questions, framed by this assumption that addressing health equity requires some engagement of meeting people's health-related social needs, and taking at face value the fact that many health systems are doing at least one of two things. One is collecting new kinds of data, and the second is using that data to either build capacity in-house to be responsive to a health-related social need, think of a food pharmacy on site, or doing some kind of community-based partnership to address health-related social needs among a local population or a patient population. So our thought was we were going to spend a considerable amount of time today on two questions. The first of which being, these are both like normative ethical questions, organizational ethics consortium. The first is going to be, what responsibilities do healthcare delivery organizations face once they have taken in health-related social needs information? So we're going to sidebar the whole question of, should they take health-related social information in? Should they not? How should they do it? Should a social worker do it? Should a doctor do it, et cetera? Put those aside for a moment and let's assume that it's happening. What is the onus on the organization by way of what to do with that information, how to respond to it, et cetera, et cetera. The second is going to be, okay, now you have information and you have a sense of what you should do with it. There's always this legitimate concern and potentially critique of these efforts that, well, a discretionary dollar is better spent on a new oncology unit than it is on a healthcare delivery organization trying to respond to some direct health-related social need. And so that's the second question we're going to try and tackle. We're going to take them in order, and unlike other kind of Zoom-based seminars that you may have been on, we're going to try and do something different. I'm going to put this question out to Monica, Laura, and Marshall. They're each going to have a go. We're going to have a little bit of crosstalk. And then right about 1:05-ish, don't hold me to it exactly, we're going to pause and take some questions. And so that'll be in the middle of this session. So if you're listening and you're not on Zoom and you're going to walk the dog or something, just know you have an opportunity to talk to us in the middle here. So about 1:05, we'll take some questions, then we'll turn back and we'll do the second question, and we'll do it the same way. So we will again end with some audience participation, but we are not punting all audience participation until the end. Sound okay? Team, Monica, Laura, Marshall,
Absolutely.
like
So
the
excited.
Avengers here.
I know.
All right, Laura, I'm going to come to you first with this first question, which, as a reminder, certainly more healthcare organizations, thanks to the work of Siren, are collecting health-related social needs data now. What responsibility does an organization that has undertaken that effort have by way of managing or acting upon that new data?
Well, first, I just want to say thank you so much for including me in today's conversation, and to the sponsors and to the med school for hosting it at all. Who doesn't want Lauren to moderate every event that they ever do, ever? So Lauren, you're hired. I'm so glad to be here. Lauren, of course, knew I would love this question because I've really spent the last decade thinking about it. I love it primarily because it leaves so much room for debate. There's really not an obvious answer. So what are the healthcare sector's roles and responsibilities when it comes to using information about social conditions to improve health? And I'm going to start by just saying out loud that I think the foundational logic model, which actually Lauren just alluded to in her opening, this foundational logic model for the rationale for the collection of social risk information, which is that we connect people facing social barriers with social services, or we provide social services ourselves, then their social risks or needs improve, and then they will get healthier. I think it's at the very least incomplete. And unfortunately, I think that a lot of the healthcare policymaking around social care has gotten stuck in that construct. So I want to give just a couple examples, and then hopefully we'll have a lively debate about it. In our own first randomized trial in San Francisco and Oakland, and then again reflected in the much bigger national demonstration of the Accountable Health Communities model, which is by far the country's largest demonstration of social services navigation, we've seen that patients who are talking about their social conditions with healthcare teams seem to do better only in part because they are subsequently connected to social services. So some do better than a control group where people are not being asked to talk about their social conditions or encouraged to share their social information about their social conditions with the clinical team, even when they are not subsequently connected to social services. So then I think there's a story that we have to start telling here, that there are other reasons why the healthcare sector should be collecting and using this information to improve care. So some of the data that other really smart researchers have done in this field suggests that it opens up more opportunities for developing healing and caring relationships. And in other instances, healthcare clinical teams are using that information about social circumstances to improve the treatment and management of disease. So like the activities that are really like traditionally in our wheelhouse, for instance, prescribing more affordable medications, dosing meds to accommodate work schedules, clustering medical visits, or providing telehealth to accommodate other life barriers. And of course, what we suggested in the National Academy's report that we wrote on this topic, the report from 2019 on integrating social care into medical care delivery to improve the nation's health, was that as anchor institutions, which Monica just defined so well, healthcare systems also can use that information about social conditions to advocate for population health and a change in the social resources landscape at the community level. But that last function really presumes that we as a society have decided that healthcare organizations are responsible for health broadly writ, not just a big business that does health on the side. And by and large, I think we've designed our healthcare system to do health on the side. So I think that deserves mention here when we're thinking about our roles and responsibilities. We can't ignore the fact that we have many competing needs as for largely profit-driven healthcare system. I'll leave it at that, but I'm really excited to hear Monica and Marshall's comments and to continue that conversation.
Marshall, I'm coming to you next. 3 to 5 minutes, responses to Laura, and you can pile on. What responsibilities do these organizations have in light of the new data they may be collecting?
I'm going to do what Laura did, which is in some ways challenging the fundamental question that in some ways is an artificial question of like, well, do health-related social needs or do systemic drivers of health, and what do we do with it as an organization? And the answer is going to be, it depends upon a variety of things. Who are we talking about? And I think like right now we're talking about healthcare delivery organizations as opposed to community-based organizations or payers or health plans. Second would be your time horizon. We're talking short term, which is, I think, the implication of the question, medium term or long term. And then what is our ultimate goal? So is it ultimately to improve overall health or to improve what we do within a healthcare delivery organization? Monica set up a typology where on one extreme, health-related social needs, on the other hand, systemic structural drivers of health. I'm going to build upon it and make it more of a continuum where it even starts before health-related social needs. For healthcare delivery organizations, I would say, like Laura said, there is healthcare stuff that we do. So, for example, guideline care with what makes good diabetes care, for example. And I think you talk to clinicians, they would be surprised to say, oh, all of a sudden now we're newly looking at health-related social needs. I mean, this is not new. That clinicians have addressed social needs as part of good medical care for eons, right? Maybe what's new is healthcare delivery organizations specifically screening for health-related social needs, and then the organization trying to decide, well, what do we do with that? So but it's a nice artificial question because in reality, any organization has opportunity costs. So if we do put a lot of effort to health-related social needs, that comes at the cost of doing basic healthcare equity work, like interpreter services, for example, right? Or I think like affordability of medication, those type of interventions. So in reality, it is a spectrum. To answer your question more directly, for the short term, I think my overall sort of like thesis is that we need to think about this intersection of the work we're already doing with general healthcare that addresses social needs and how it integrates with now this new emphasis upon the organization doing formal screening. And so in the short term, it means action. So I think all three of us are going to agree that you just don't screen and just leave the data there. You have to do something with it and in action and developing the programs that go beyond just purely screening or just go beyond purely screening referral to actually a program that's going to actually do something that will actually help that patient.
I can't help myself. I got to jump right back in. But Marshall, you're saying we got to do something. But I heard Laura say it's enough to sometimes just ask and know as a clinician, that you don't have to like programmatically stand up a response or refer that person to services.
Well, actually, so just a clarification. I don't think it's okay to ask and know without validating, opening up a conversation, having a conversation about how that impedes access to health promoting activities. So there's the list of interventions that CMS and NCQA are talking about is not just connection to services. There's actually an intervention, can be a conversation, a validation, some kind of, so I agree wholeheartedly with Marshall that it's doing something, but that range of something is much wider than I think the foundational conceptual model that we've developed in the field.
Acknowledgement is an intervention.
Right.
Yes.
Monica, I want to bring you in.
Yeah, I'm super excited because I get to comment on both of those. So I would, and then add my own. I'll try and do it quickly. So I think what I'm hearing or how I'm interpreting what Laura was saying is that people feel like, oh, someone cares that I'm struggling. And that's something that is very important to me and my lived experience is being and that may impact my health is actually being understood by people who may not be having that same experience, that validation. And so that's why it feels good to patients. What I would say is that right now, as it's still sort of in its infancy stage, it's being delivered by compassionate, loving doctors who do care about their patients. As we scale up and sort of mechanize the process and make it more like, you know, do you have so-and-so? Do you have so, you know, it's going to lose some of the warm, fuzzy edges. And so some of that positive glow that we're getting is going to diminish. And so one of the tricks or the challenges for us is going to be, how do we maintain that sense of love that and acknowledgement that patients are feeling when we ask those questions that benefit to, you know, for the patient-provider relationship as we scale up. Marshall, when you mentioned that, and when we do these efforts, it's going to come at the cost of interpreter services or other health equity, I would challenge and say that, why don't we say it comes at the cost of, you know, something that is an unnecessary fringe, high cost, low, something that we don't need in the healthcare system. You know, why does it have to come from the health equity pie? Why can't it come from the part of the pie, you know, the excess, you know, fatty part of the whatever. So I think that there's lots of sources. I'm mixing all kind of analogies here, but I think there's extra things that we could trim that don't have to be health equity related, and we can still add this to it.
Right.
Lauren,
Yeah. But I think what your comment does is it shows that we have to expand the conversation. So again,
yes,
we're not going to be very productive if we just say, well, HR, health social needs versus systemic structural drivers. It really is sort of a question of the overall healthcare system, the overall allocation of dollars and resources and effort and leadership attention. How do we divide that? As well as what is healthcare good at? So there's been a lot of great thought pieces, Seth Berkowitz, Sherry Glee, Tom Diano, talking about, on one hand, when we get to systemic structural drivers of health, you got to be really careful about healthcare delivery organizations, throwing the weight around in something like housing, incarceration, or education, because it's not what we're expert at. And there's a danger that we're the big actors with money that we can do a lot of harm there, right? At the same time, though, if we don't think about then, because we just do so poorly overall in the nation regarding equity, you know, addressing health-related social needs through screening is just one small component. There's all the other basic stuff about like doing holistic patient-centered care that tailors care to individuals, et cetera, that Laura was starting to allude to, that really should be on the table also. And I agree 100% that the ultimate answer is basically distributed justice, target universalism, where everyone being for great health for all, and then we appropriately tailor services to those with more needs, get more resources. But that's the wider discussion. So in some ways, I think maybe we're evolving to that. That's the real discussion, as opposed to an artificial discussion about, well, what do we specifically do about health-related social needs?
yes. And my third point, someone actually already put in the chat. And so I would say that one of the obligations is to first do no harm. And that with the data that we're collecting, and someone put that we're already doing harm. And so we as do-gooders are thinking about all the benefits that can happen when we collect information, because we want to act in good ways on this information. But we only have to open our eyes and watch Fox News to see that there are a lot of not do-gooders who aren't, who may act differently on this information, who intentionally or subconsciously may use patients' information about their additional vulnerabilities in ways that may harm them, to leave them out of services. We have to, as we are thinking about the increasing role of artificial intelligence and merging big data sets, what does that mean as far as the information, the very, very sensitive information that patients have entrusted to their warm, fuzzy, encounter, as it then sort of makes its way into other systems that they may not have intended it to. And so I think that one of the most important goals or obligations of health systems is to protect patients and do no harm with the data that they've collected.
Awesome. We've got just a couple minutes for us to chat amongst ourselves, and then I'm going to bring in a couple of the questions that have already been posed in the chat, which are great. Thank you, team. And then we can, if anyone wants to raise their hand and actually use your voice, we welcome that too. Marshall, I wanted to come back to you on one thing, which is that I think I heard you say that, look, the responsibilities an organization has differ, whether they are trying to use this data to improve healthcare or kind of do healthcare versus pursue something broader and more expansive like health. And I just wondered if you could double down and say, like, what is important about that distinction in your mind that would change the obligations that the organization faces?
Maybe I'd focus on two different elements. So one is like, is our goal improving health, which I think is going to be yes. The second is, what are we good at? Where is our relative effort likely to lead to greater gains, right? Or another way, what are the things where we should basically be doing more on our own versus things that are more the level of coalition and partnership work and all. So, overall, I think that healthcare should get involved in the whole spectrum, from the very healthcare-oriented things, the health-related social needs, the systemic structural drivers of health. The further you get on that spectrum, the systemic structural drivers of health, maybe there's less involvement of healthcare and more and more involvement of our community partners and social service agencies and whatnot. So maybe that's a better wording. It's this trade-off between we all have healthless outcome, and then where do we sort of allocate more of our resources and effort regarding things we can do more, relatively more on our own, versus more that we are going to be in a partnership position. And towards the latter part of it, the systemic structures, we are a partner and probably not a leader in terms of like driving housing policy.
Laura, Monica, anything you want to jump on that? Or I had one other question I wanted to put to you.
Well, Laura, you're on mute.
I'll just say that in the National Academy framework work that we did in 2019, and I put the link in the chat, we said exactly that, Marshall. So we described sort of a spectrum of ways that the healthcare sector might lean in to work around social determinants broadly writ, including health-related social needs. I actually don't love the term health-related social needs, because if you really think about it, what's not health-related? So I would call them downstream social risk assets and needs, and then more upstream structural drivers. And I think the committee was pretty unanimous in saying exactly that, which was on the upstream side, that's a place where the healthcare sector has to be a good ally and a partner and follow the lead of the organizations and the people who really understand the community level needs. Whereas we can be a real leader on the healthcare side, and the sort of how do these social risk assets and needs impact medical care, treatment, and management. Anyway, so just concurring and giving a framework for it.
Yes.
I just wanted to put out there something that I have sometimes been sort of accused of, which is duty dumping. People will hear me talk about the importance of doing something socially related, and they basically look at me and say, like, Lauren, it's not really healthcare's job, and it's only because you don't know who else to pin that responsibility on that you pin it on healthcare, and that's unfair. It's essentially duty dumping, to use Alan Buchanan's language. And I just wanted to give each of you like an opportunity to respond, because I think it's sort of a fair critique, and I have my own way of coming back at that, but I just wondered if you either face this in your own work or you have your own line of reasoning that either says like, yeah, it is, and I'm fine with it, or no, this isn't duty dumping. That's something else altogether.
I always tell medical students that our goal is to have our patients be as healthy as possible. And providing medical care is only one of the factors that will help them be healthy. And we get very little public health training as physicians. We get very little training about how our health systems work, health policy, the financing, yet we're embedded, in these systems. But if we're going to be effective caregivers for our patients who are navigating these systems and whose health is affected by so many things that are not medical care, and our primary goal is to help these people walk to wellness, then if we're their health advocate, then it is our job to learn about these things. We have the rest of our lives to learn about these things. and to be part of the team whose job it is to make sure that our patients can be as healthy as possible.
So I'm going to reinforce Monica's comments and add maybe a conceptualization of advocacy within healthcare policy and advocacy within more general public policy. So right now, there aren't great incentives as a whole still to do significant social drivers of health work within healthcare, or equity work for that matter too, although it is improving. So to the extent then that we can advocate within healthcare policy for these newer payment schemes, newer internal payment model schemes with an equity lens that would make it more in the business interests of the healthcare delivery organizations of the world to address social drivers of health and equity. That's one sort of phase of advocacy. The second is broader public policy advocacy regarding the relative ratio of social service and healthcare spending. And Lauren, I mean, you wrote the seminal research and articles in this field. So that goes beyond sort of healthcare policy. So this is a wider sort of like a societal decision regarding the allocation of resources, what are the ethical values embedded within that, and then just, the poor Europe politicking and advocating regarding that. So that's another level, and I agree with Monica that we should be involved into whatever extent we feel comfortable. But I do believe it is like also part of our responsibility.
I'm gonna hold off on answering that question because it's so connected to the next question that I think we're gonna get into that I want to reserve my comments until we're really talking about these discretionary dollars.
Fine. I appreciate that. There have been some really nice questions popping up in the chat. I will keep an eye if anyone wants to raise their hands and use their voice. I will do my best to unmute or get you unmuted so you can do that. But otherwise, there's Laura, I know you want to take this one, but David Sontag put in the chat a question about whether or not the obligation to address health-related social needs might spring forth from sort of a obligation to address moral distress among staff rather than solely a patient concern.
I really appreciate the question. I think it's so wise because we have seen, so there have been a couple of studies, primarily survey studies about this sense that providers who have the capacity or feel like their organization has the capacity to quote unquote resolve or reduce social risks among their patient population feel less moral distress. They're less burned out. They're happier with the care that they provide. So I do think that there is a component here of there may be an added benefit of addressing social risk that is not solely a patient outcome, but that we retain providers in safety net settings, that means that they provide better care, and that actually has its own health outcome. I do want to just also elevate two other things for us to think about when we think about this question of moral distress. We've done two big reviews of the literature that has emerged in this area that are relevant to this. We've done a lot of reviews, but two of the reviews, one is on providers and provider broadly writ, so front desk staff, frontline staff, advanced practice clinicians, MDs, social workers, community health workers, the whole gamut, and what their thoughts are about social risk screening and interventions. And increasingly, we're doing some of our own research on what they think constitutes high quality social care. And then also a review on patients and what they think the roles and responsibilities are of healthcare systems. And in those reviews, a surprising disconnect emerged. And David, I'm still getting back to your question, I promise. What we heard from the healthcare provider group, again, broadly writ, was that they think that there's an obligation to work specifically, connect people with social services, reduce the social risk factor. And what we heard from the patients was, yeah, I'd like you to approach it with a good intention, but really I want you to know about this. I want you to care. I mean, our bar is so low in healthcare. Exactly what Monica was saying. I want you to hear me, and by and large, I know about a lot of those social services. I've tried them out, but I want you to understand what I'm facing. And that disconnect is so striking to me that I think healthcare providers in some ways are using their assumptions about this as a way of not doing all that other stuff that the patients really want. So I just want us to think about the moral distress in a maybe that's a selfish moral distress. Maybe that's like taking us away from what the patient provider communication really needs to be about. It's not, I don't want anybody to misconstrue me. I do believe that to the extent possible, I think we should be trying to connect people with social resources. That feels ethically right. It is instinctive. It intuitively obvious, but I just don't want it to also prevent us from doing the really important, good patient care, shared decision-making work that can also be connected to to collecting information about social risks and communicating with our patients in a meaningful and healing way.
I'd like to add onto Laura's comments. I thought it was terrific. I agree with you 100%, Laura. I think like the four of us, on screen now, we have a kind of similar bent of wanting to integrate everything from the abstract ethical to very practical. And another part of it is that in some ways this all fits together into an overall whole. So I want to talk a little bit about this. So this is one area too where like the moral distress of providers, staff is related to the well-being and burnout. And this is one of the areas where like even sort of recalcitrant healthcare delivery organizations, they see the cost of burnout, staff turnover, financial and morale-wise. And so this is one of the arguments that can be very powerful in terms of like getting leadership to pay more attention to social determinants of health. So I'm glad you raised that, David. This part about how it all fits together. So ultimately, like you can't just focus upon the technical solutions to things like, oh, wait, what is the screening instrument for health-related social needs? If the goal is organizational change that actually does something, the cultural aspects are just as important for change and buy-in for which to happen. So something like increasing and nurturing, supporting the intrinsic motivation that the vast majority of healthcare people have in doing the right thing and serving patients is really important. And so this idea of like, well, moral distress or people not feeling terribly because they're not able to provide the care they know the patient's needs, that dovetail then in terms of then, well, how can you do the various types of care transformation, quality improvement, et cetera, to have those systems that enable then the healthcare providers and staff to succeed in their task. So the cultural part is very important. So I think like over the course of the 90 minutes, we're going to see it all coming together of like how it all fits into a whole.
Super. All right. I'm going to move us on to the second question only because I too can feel the linkages. And if we move now, perhaps we have a little more time at the end to come back and do some more questions from other folks. So now we're going to try and broaden the frame a little bit and say, all right, let's say that an organization takes in health-related social needs data and it is using it responsibly. And we're trying to think about how a healthcare delivery organization should use resources, not only dollars, but also attention, right? Because there's just like limited time in the day and staff resources. And so the question is a discretionary healthcare dollar better spent addressing a specific patient's health-related social needs or invested in kind of community level social determinants like employment program or new affordable housing? And I think here we can think about better in terms of like getting us closer to Monica's conception of equity. And, if you have an alternative idea about what would be better, like you want to take a radical departure and say better would be putting money in proton beam, I welcome that too. But for now, we've got these two poles of like standing up their own health-related social needs kind of programming and response versus this broader investment that might not have anything to do with the particular skills and experiences of healthcare delivery, and are really more kind of structural, if you will. Maybe we'll go Marshall, Monica, Laura.
Yeah, so I think we've been talking about this all along, and to me, it's sort of it requires a nuanced answer, So So I think a lot of population health management efforts try to stratify patients by combined risk, medical and social risk and all. And so they're going to be like the highest risk folks that are the ones, for example, where some of the housing interventions have been shown to have a pretty good cost effectiveness in terms of that. And so certainly that they're going to be then some parts of the overall population, depending upon, again, like your patient pool that you care for, where that's going to make a lot of sense. Um, uh, Again, like a lot of like the most effective things are going to be closer to like where we have the expertise, where we're just not doing well with healthcare, more that intersection of healthcare and the social care that, again, has always been done by providers, but hasn't been done very well in terms of systems being set up to support that. Gets back to that moral distress question. At this intersection of the question of well, healthcare dollars and then investing in broader social structural drivers of health. I think a lot of it is going to be more on that level of like the partnership, the coalition building. Right now, again, partly again, to some extent, like healthcare organizations, they have to work under the systems that on the rules we've set up, which are just not very good rules of incentivizing currently greed as opposed to either health or equity. But again, it gets back to that issue that it is changing, and the more we advocate and the more it changes so that there is more business case to work on equity, to work on social drivers of health, there may be them, okay, we will sort of gradually shift towards less very healthcare centric and more towards that spectrum of social drivers. But again, it's the continuum, and it has to be talked about in terms of the evolving policy context and overall system.
Monica?
Yeah, so I guess I would say a couple of things. My official party position party, whatever. My official stance is that I want healthcare institutions to recognize that they're one of the few anchor institutions that we have left. We don't have big tire, we just don't, unless they're, tech firms or whatever. So there is an additional societal responsibility for anchor businesses in our communities. And there has historically been one. There should currently be one. And if healthcare systems are now playing that role, then we should say that, hey, you're the new kid playing this role. And what does that mean for the communities that you're serving? What additional responsibility comes with that role? And so that's my party stance as far as thinking about a community in terms of education and other supports. The other is that until that's like something that everyone's on board with, every healthcare organization has things that they're currently doing that they can do differently. So they, and this is part of what the anchor strategy is, they currently have to subcontract with someone to do their laundry, right? All that linen. I learned this and I was horrified. Many hospitals contract with prison systems because the prison systems use essentially slave labor, right? Use disproportionately brown and Black people who work for, pennies or free. The 13th Amendment, is sort of that loophole to slavery. And so it's so cheap. So capitalism sort of, pushing these structural inequities. And they could say, well, it's the best price. But if you're committed to equity, then you say, how about we not try and support slavery, and we'll try and use, minority-owned businesses right here in our community. So we already are going to have to pay for linen. Let's do it in a way that seems equitable and supports our community. We're already going to have to, try and have a portfolio that keeps us, in the black. how do we invest that in ways that are so and so? We already are having to do these kinds of services. Can't we take a health equity or community engagement, community investment lens? You know, why don't we have a goal of making sure that our hires for these various services are X% from our surrounding community? And if they need additional training or whatever, we have some spaces and places for that, so that the direct communities that we're serving for clinical care, we're also serving as an employment hub. And we can't just say, well, we'd like to, if they can meet the, yeah, but and so the daily operations of a healthcare center don't have to change that much for them to be engines of equity as well.
I love that. Thanks, Monica. It reframes the whole thing from like a scope creep concern to a more kind of laser focused, just change the chassis of the place. Laura.
Yes, yes, and yes. So I'm gonna just do my best to like take the comments of the smart people who went first and put them all into one common thread, because I think, you know, the benefit of Marshall and Monica and I all knowing each other is also that we often agree, even when we sometimes like have some small differences of opinion. But I just want to like start with the question. So I talked about this question, you know, in thinking about this conversation with the Siren Core team yesterday. And I have to say there was pretty unanimous curiosity about the term discretionary. So we ended up sort of bantering about how the healthcare system differentiates between what is a core business dollar and what is not. And I think ultimately it's just really about society's expectations. So if healthcare stopped attending to individual patients and instead said, we'd now really like to invest in redesigning healthy communities, we wouldn't have a healthcare system and people would be up in arms, right? So it's clearly not about making the decision that healthcare stops investing in individual patients. We can't stop trying to increase access to care for people who don't easily access care, or we have to, as Marshall was pointing out, improve our ability to provide language concordant and culturally competent care in order to move towards equity. We have to strengthen our healthcare team's capacity to engage, and I'll just come back to it because Monica's such an amazing champion for this, but engage in shared decision-making. So like care that is really tailored to the people in front of us. And if a patient doesn't have access to food, that's an immediate health problem too. So all of that is a part of our responsibility when attending to the social and economic differences that affect that delivery of healthcare. But the broader question that you're asking makes me think about that slide from the old public health parable that Cameron Jones has kind of reformulated about the cliff. So do you attend to the people who are bleeding at the bottom of the cliff, or the fact that the safety rail is broken at the top? And is the safety rail only the responsibility of other sectors? So this is kind of getting back to my answer about your duty dumping question. So if so, which are the sectors that are responsible for that? You know, is it the Department of Transportation? Is it the people, the public health departments? Like, you know, who's responsible there? And so this is just like to tie in Marshall's comment. We had the opportunity to host Sherry Gliad after her amazing commentary about like, no, the healthcare system should not be involved. And then Stacy Lindau and Seth Berkowitz in a conversation about like, okay, what is the responsibility of the healthcare sector here? And the takeaway that I had from that conversation with these brilliant people is that of course we have to do both, because the work for individuals, all those things that I just said, cannot be done or done well without a simultaneous investment in community advocacy. So in parallel, the healthcare sector's power and money and a capacity for community investment makes our advocacy role so much more influential. So I only see a both and when answering this question. And then I just want to double down. I did this in the chat, but I want to double down on Monica's comment that some of our own healthcare policies and practices are a cause for worsening both patient and community level adversity. So when healthcare is unaffordable, when we send people into medical debt, when we refer people to debt collectors, we garnish their wages, we hire non-locally, we have subcontractors who are not consistent with mission, vision, values of the community, when we avoid paying living wages to healthcare staff in our neighborhoods, we are exacerbating inequity. And I wouldn't want to let us off the hook for that. And again, I think this comes back to this question of the discretionary dollar. So if the healthcare enterprise is about really fundamentally making money, then the discretionary dollar is absolutely different. The definition of what is discretionary is totally different than if our enterprise is about health. And we as a society have not adequately grappled with that, and that's a problem. Whew, I'm done.
That's great, Laura. Let me add a few more comments. So I think we all agree regarding like anchor institutions and that being sort of very, very core to what institutions should be doing and all. You raised this question of well, it's sort of well, the system as it is set up, which is essentially the relatively unfettered free market, and then profit being the goal here. Don Berwick's great recent viewpoint on greed, right? Versus like trying to fundamentally change the policies, regulations, and incentives so that global health or societal health would be the goal. I'm currently like reading this book by an Italian economist, Maureen Mazzucato, called Mission Economy. This is the argument she makes that it's called industrial policy. That on the whole, the U.S. bows to the altar of the free market and in fact tries to protect the free market as like the religion, principle number one, as opposed to what many other countries do better is thinking about, can we come up with an industrial policy looking at public-private partnerships and combined policy that looks at a societal good, i.e. maximizing the public's health as the goal, and then try to create the regulatory and free market incentives for that goal as opposed to pure profit. I think that's what we're talking about in terms of like we're talking about advocacy and, well, what is this policy change that we're looking for? Right now, we have this so far to go, but it's getting better. Yeah.
Monica, do you want to layer on top?
Yeah, I was with you, Marshall, until that last little thing about it's getting better. Is it getting better?
We'll talk about that in a moment.
Okay.
We have time, guys. So it's about 1:30. And my thought was we have about 10 minutes to just chat amongst ourselves before we turn back to folks. So Monica, if you want to go back on, is it getting better? I could put questions for, but we can double back over anything that interests the four of us.
Yeah, I mean, it seems the data on the widening wealth gap continues to increase. And for me, it was, I don't know how many years ago, I think around 5. Remember I was telling you about this, that there are like 4 conditions that make the country ripe for a civil war, and we had all of them. And this was 5 to 6 years ago, and one of them was increasing nationalism. One was much widening wealth inequality, and things like that. And so I don't think that wealth gap is getting better.
Well, I don't argue with that, and I don't argue with like some of the existential concerns that you're raising about the country overall. I was saying like a little more narrowly within healthcare policy, thinking about then for the big stakeholders, i.e. like CMS or the industry and whatnot. Whereas like even 3 years ago, I don't think CMS or much of industry was ready in terms of thinking about intentionally designing their policies to advance health equity. This is now much more on the radar screen, and this is the work like I probably do with the Robert Johnson Foundation and CMS that it is specifically trying to create like the incentives in the system and payment flows so that it sends people in interest to work on equity and to work on social drivers of health. Long way to go, but going from like just not even on the radar screen all 3 years to go to where these groups are, that's huge progress. And
yes, I agree.
It's just an important driver of things. And with the money thing is aligned, then there's a chance.
I agree.
I will throw down that asked myself the question on a micro level about whether or not we're moving the needle forward around social care. So like, I think you're asking really big, broad questions about, are we moving forward on health and health equity generally? If you look at the micro level around social care, I don't know. I feel like, I feel like I'm to blame in part for some of the enthusiasm around systematic social risk screening. So Lauren put it in terms of thinking, and I think maybe blaming, because I'm not sure that I would want us to be systematically screening for social risk across all populations, all settings, with the kind of frequency that that's being suggested by some of the standard setting organizations in the field right now. And that I don't know. Like, we're using quantity of screening as a proxy for what really may be poor quality of screening and may undermine patient relationships, as I think we've seen it, some of the concerns arise in the chat. So I don't know if we're moving ahead in a positive way, or if this is going to be a colossal mess. And I think the reason why I'm glad to be a researcher is I get to say, well, all I ever said was we need more evidence. But I do think it's incumbent on us to look at the evidence, see what's happening for patients, develop maybe some patient-centered metrics where we can actually evaluate that, and then redirect. Because if we don't redirect, like, woe is me, like, we're not learning from this grand experiment that we're calling social care integration.
Mhm.
I like to reinforce what you just said, Laura. There'll be some people that say, well, any incremental advance is positive. So they say, okay, boy, a process measure like CMS, like having like these 5 metrics for screening for health-related social needs, it's not the same as improving the actual outcome, but well, it's a step, right? And I think like your answer is the real answer, that it can be a positive step, but only if we think about the overall process of change of behaviors of individuals and organizations, and does it really lead to health outcomes? And again, like, social needs is not unique to this. This is the general quality of care measurement and metric field, that it's the difference between, like, well, blindly doing this measurement versus, are you really linking it to both, again, a technical process of your redesign of care systems and a culture that allows it to happen, and also things like the incentive systems and reward systems and payment, et cetera, so that it actually happens. So I love what you just said, that screening has to be thought about within a wider context of what is required for there to actually be the changes that lead to the better outcomes.
I couldn't agree more. And I'm just sitting here thinking, man, healthcare delivery organizations kind of get screwed 2 ways. One is like, sort of as Monica was alluding to, they may not have chosen to be the only game in town, to be the only anchor institution left. Like, no one asked, do you want all of the big businesses to leave? Do you want, local government to fall down on the job? Now, we could maybe put to them, you've captured some elements of government that should be regulating you, and
Right.
that is kind of your fault. But let's hold it aside for a moment. They didn't totally sign up for this. And yet I myself have said, look, you may not have chosen it, but here you are. And so that's where some allegations of duty dumping I'm willing to wear, that, like, sometimes you're the only game in town, so you got to do it. This is what rule of rescue means. But then flashing to Marshall's kind of comments here, so they're kind of screwed. They're the only game in town, and so we look to them to do more than maybe traditional medical care. But then the only mechanism by which they have to really build things into the mainframe of what they do is this like huge research enterprise that leads to a process measure that might lead to an outcome measure that's all going to get like kind of channeled through some kind of fee for service initially, and then maybe a value-based care, something or other. And I'm facing this with some of my other work on trust now. Like, there's the same impulse to maybe we should measure trust, maybe we should incentivize trust. And I think, oh dear God, I see what's coming. And I really feel my inner chaplain coming out like, no, 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 no. There's something like sacred and profound about it. Do not
Mhm.
put trust through that ringer. It will come out the other side unrecognizable. I do not want it in the CAP survey. I don't want it in the Press Ganey survey. I don't want it anywhere. And of course, there's a whole bunch of other people who say like, no, no, that's winning, Lauren. You're winning when they're talking about that. And so I really just feel between a rock and a hard place here, because
Mhm.
Marshall's comments illustrate the way in which, like, if we want health equity or addressing health-related social needs, or even listening to health-related social needs to be part of the core of what health care delivery systems think they ought to do, it feels like the way to do that is find a way to get it paid for, because we've said they're like competitive businesses and they're looking to at least break even. But the path from here to there is just like a gut punch if you think that the value in asking about health-related social needs is something about listening to people and like bearing witness to the pain that they're reporting to you about the state of their life beyond the clinical encounter.
I want
And I
to channel.
think, okay.
Go ahead, Monica. Sorry.
No, I was just going to say you hit the nail on the head, because our healthcare system itself is dysfunctional. You know, we're trying to place all of these good intentions, and I use the word love all the time, but it's because, you know, I want people to feel loved, you know, and I hug them all the time. But we're trying to put all of that sort of emotional intelligence on this capitalistic system where, you know, and it just doesn't fit, you know. Did you ever see those billboards that had like animals wearing like blonde wigs and just other ridiculous things just to make us reflect on how ridiculous we look when we wear fur coats, you know? And so, you know, things that just don't go together. And so like other countries have better functioning health systems that are made to produce health. And our system really isn't. And so us trying to hang all this stuff onto this system is a challenge, because the system is so challenging.
Try to integrate this. So, you know, I love quoting Monica that often she'll say, well, it's all about the love. And there's a lot of merit in that, that at the end of the day, a lot of like change and what happens in organization depends upon relationships and trust and love, right? And remember, we talked a little bit earlier that these technical things, so a performance metric or, you know, a payment scheme and whatnot, and they're important. I mean, this is where accountability, that change requires some level of accountability, you know, the individual, the organization, for things to sort of progress. At the same time, it's not going to work if you just focus on the technical and then you don't address culture, of which a large part of it are things like relationships, thinking about power and hierarchy. So a lot of equity issues devolve down to power issues, right? Whether it's like with the community or even within organizations, healthcare delivery organizations, there's a lot of power issues and who's at the table, who gets to speak, who's heard, et cetera. So again, I'll say, I think that, and I think there is value in explicitly talking about this. So for example, just talk about, well, should we have some type of performance metrics to look at the culture of an organization and degree that is a culture that is equitable? We're doing all the stuff we've talked about in terms of like hiring and retention and community outreach and anchor institution principles, et cetera. You know, principles can be, well, metrics can be gamed, right? But at least put it on the table. It has to be accompanied then with the cultural work. So I think that they're not either, again, that can be another way, either or, sort of a yes and.
We're going to go back to some Q&A, but I just, before we did that, wanted to give anyone else a chance. This topic is so nuanced and you all have been at this for a long time. Is there anything that you want to double back to and say, like, don't mishear me? Or like, I frequently get misinterpreted as saying X, and I just want to be super clear that I'm saying X prime, or I'm saying Y. I got to give one of those about, I often get misheard as saying like, oh, everything is healthcare's responsibility. So sometimes I find that a useful thing to offer.
I think I already auto-corrected, so I think I'm good.
Let me give it another lens here that I think one of the things that's hard about the social drivers field or health equity in general is that because it's so encompassing, at any given time, you're looking at one small piece of the puzzle. But I think that to do that well, you also have to think about the whole picture at the same time. And so that's why, I mentioned, well, from the beginning, think about a continuum from very healthcare oriented to health-related social needs to systemic social drivers of health. Think about, well, is your time course short-term, medium-term, long-term? What's in the realm of, oh, I can do this right now versus I need to be like an advocate and think about the coalition building and partnerships and more long-term, obviously, whether it's like for specific policies or some things that's a level of awareness raising and all. And I think like everyone on this screen here now, this is what we do, right? But just being very explicit about it so that, that's why like I was a little bit leery with like, this being a sort of a unrealistic, simplistic questions, the ways that some of them originally worded. It really is more nuanced that we simplify. But in reality, we need to think about the overall picture and be very explicit about like when and where and how.
And then, Lauren, I'm just curious as to your thoughts about this because you spend a lot of time in this space.
Open field, my thoughts. Well, I'll give you one thought, which is just a framework that I've actually shared with an organizational consortium group previously. And it's that like, I think this is where I may have some daylight between me and the rest of the panel. And I'm a non-clinician, so I think that may be responsible for it. But in like I think it's worth thinking about a first best world and a second best world, or an ideal case and a non-ideal case. And this is where I find some fertile footing with the Dean Gleeds and Tom Dianos of the world, because I say, look, first best, no, I don't think healthcare needs to be in this game much. They get to be pretty laser focused on healthcare because there's like a plentiful array of community-based organizations and everyone pays a living wage and our communities aren't living in the shadow of redlining and it's wonderful. And healthcare gets to just like cleave off all the other stuff and say like, you've come to me with a tumor and let me address your tumor and then everything else will be taken care of.
It's just Lauren, I want to hear the rest of this, but I just want to say that taking care of your tumor means you have to get to the healthcare provider to address your tumor. It means that you have to be able to pay for the tumor treatment. It means that you have to be able to access the medications that you have to take after. So there's so many things that are just like so integrated in there, right?
Yes, but in my ideal case, those things are all taken care of. People have money, people have insurance, they have cars. So we're thinking
we all want to
ideal. And then the challenge in the place where it gets messy is like, we're a long way from that. We live in a highly non-ideal world. But I find that a useful tool because like I said, some people really want to argue like, oh, healthcare doesn't have special skills in this, and so they shouldn't do it. And I say, they may not, but it's a non-ideal world. Like the cavalry is not coming. We got to figure it out. We got to either learn up or we got to find partners. We got to do something. And the term that I have found sort of useful is like, I look at folks who are concerned and I say like, don't you think there's moral urgency here? And if there is moral urgency, like somebody's got to do something and get caught trying. Like that's what I would prefer to see. Instead of sitting back and saying like, oh no, not my job, someone else's job. Well, whose job is it? I don't really know. Get caught trying.
I love that. Get caught trying.
So those are some of my brief remarks, but Laura, you can come back to me if you think that's still.
No, I love that. I totally love that. There's no daylight. Like, no, I'm there with you 100%. I really love the work that Seth and Sanjay roped me into a last year sometime where they asked to like really think hard about when does healthcare actually have some special expertise. And Seth has this great example of the medically tailored meals where he's like, you know what, there are times when we really are the ones who can tell you
Mhm.
what that food box should look like. Like there's a moment when, you know, having some of these services actually is going to make a huge difference for the healthcare outcome that we're talking about, and that those may be the times where the healthcare system needs to lean in even more. So there may be like okay, well, now there's a moral imperative because the cavalry is not coming. And then maybe there's like an interim place where it's like, no, healthcare really has some expertise and cavalry may be there, but we should be informing and involved. And then there's like this, you know, dream world where we all want to live, where lots of shiny, happy people, and we all have everything that we need and want others to have in a real equity oriented universe. And I love that universe, but we're so not there.
And I just really think like healthcare leadership is often fearful of acknowledging that they have a responsibility, or that like social determinants of health really influence medical care outcomes, because they fear that that puts them on the hook for like such a broad swath of activity. And then they say like, well, then I'm on the hook, and then I'm going to get, you know, scolded by people who say like, I haven't delivered on like A through J, but like, I don't have time, I don't have money, I don't have resources to doing that. And I just feel like, as I often feel about healthcare leadership, they underestimate the tolerance for complexity among the communities that they serve. And I think if healthcare leadership were willing to say, like, look, in an ideal world, we wouldn't probably have to do this. We live in a non-ideal world. We have limited resources, but we know that this is important. And we're going to make every effort to use the resources we do have with integrity, to be responsive to the non-idealness of the world. And there are going to be times where we're going to do X and you're going to wish we did C, or where you do J and you wish we did A. And we welcome that feedback, but we're trying, you know, and that's what I mean by like, get caught trying, do something.
I love
And,
it. There's
and narrate what you're doing. Because again, I think people would give you a lot of credit if you just like acknowledged that you can't do everything. People know you can't do everything. Do something.
But is there, I feel like there's a lot of daylight between physician leaders and business leaders in healthcare, and how we see what we see as being important. And so that is oversimplifying things, but I do think that there's some real daylight there.
Yeah.
There's a paper that came out that I was pretty excited about when I saw the headline of it, from Anna Steves-Rees and a group that was studying the accountable health communities implementation in Oregon a few years ago, and they were looking at like what makes social risk screening more acceptable to patients, like what makes it feel better to patients. And I was like, oh, I'm so glad somebody's looking at that question. And they came up with a framework, and there were 4 things in the framework, and one of them was like a kind demeanor. I was just like, oh my God, the bar is so low. Really? Is that really what's happening? And so I really love your frame of do something, narrate what you're doing, like approach it with a good intention, because patients really, like, the bar is so low for patients, and they are going to understand if you have an intention to help. Like, patients really get that. Like, they want you to be kind. They don't expect that you're going to solve all the social ills. They want you to be kind. And I mean, maybe it's good that we've set the bar so low that that's what they expect, but I don't really believe that. But I love your frame, Lauren.
I'd like to reinforce that point about communication. So in some ways, we talked about communication, shared decision making, more on a clinician patient level. There's the communication of what is the overall storyline we're trying to tell about social drivers of health, and where they fit in this pathway to overall health. And we haven't done a particularly good job of it. You know, like I think like that was part of what you were saying, Lauren, of like being able to communicate the message to a variety of stakeholders, including the community, of like, well, you know, well, here's levers we have under our control. We have limited resources. We're deciding to do this and this level of involvement in systemic social drivers because, right? Really important. You know, Monica's point about like the daylight between medical leadership and business leadership, you know, I think that's been my experience also in general. Like that is true, you know, and not surprising because of like the clinical background of medical leadership, right? But this part of the solution there is, well, part of the storytelling, right, that we're talking about now, but then also it is the policy changes that make it more in the business interest to do this. We're talking about regarding SDOH and structural drivers. We've met with Seth Berkowitz a number of times, so I'm going to actually plug his book that I don't know if you've seen it yet, but it just came out. But he has a great book, which I think is particularly relevant for this audience because he talks about social drivers of health in at multiple levels, from the perspective of just the pure ethics and schools of thought regarding distributed justice and other sort of forms of ethics, to the practical part of like, what does it mean for individual patient care as a clinician, to the intermediary messy part we're talking about of policy change. It's worth reading for those who are interested in the topics we've talked about over the past 90 minutes.
I also just wanted to plug his recent Milbank piece, which I adored. This was Seth Berkowitz in Milbank Quarterly, probably 2024, although maybe late 2023, and he wrote a piece. I have spent a number of years working on developing a model for cross-sector collaboration called the Collaborative Approach to Public Goods Investment. It works sort of under some conditions in some places, but I think if my partner Lennon was here, we would both be quite humble about the way in which it has really facilitated a lot of cross-sector collaboration that led to social determinant of health or just social investment generally. Cleveland is a bright spot. Many other places have tried and found it just too administratively burdensome. Seth's piece came out and said, we talk a lot about the need for cross-sector collaboration. How about just social change? And it's a piece that kind of calls out that we have been calling for cross-sector collaboration for, like vociferously for a decade and probably more than that. But that has been like a key hallmark of all sorts of philanthropic efforts, all sorts of CMS efforts. Cross-sector collaboration, cross-sector collaboration. This is the way we let healthcare do healthcare and we let other people do other things, and you just talk to each other and work together. And it's hard, man. And it doesn't yield quick results by any means. And Seth's take was like, it's really hard. What if we just like really lobbied for different political choices about where we put money and what was taken for granted? And I adore his work generally, but I thought that was particularly kind of on the money as someone who has toiled in the realm of cross-sector collaboration.
Have we covered the questions in chat?
Yeah, we could take this. I don't know that this is a question, but we could look at Anne Marie's. One challenging aspect is that funds coming from philanthropy or private foundations have really thrived in a capitalistic society, not aligned with going towards this kind of work. So something like funding for childhood cancer seems to be more palatable because it doesn't disrupt anyone's narrative of success and the framework that systemic structural discussions like this one may be kind of upsetting. Yeah, I mean, I don't know if folks have reactions to that one, but
I'll
yeah,
at the risk of like, I don't know, people may have strong negative reactions, but I've been really impressed that with some philanthropy that I think is sort of really trying to much more fundamentally shift the conversation and the dollars and the practices that go along with really trying to move the needle on health equity and racial health equity. I mean, RWJ is doing this massive strategic and I really believe fundamental change in the way that they operate as a philanthropy. And they are the country's largest and maybe the world's largest health philanthropy. So I'm hoping that others will follow, but I think, if you look at their new strategic planning documents and talk with their teams, like they are really trying to do things differently when it comes to making decisions about where to give and how to give and what their own internal practices look like, as well as where their money goes. So I'm hopeful, Anne-Marie, that we're going to see a shift. I mean, I think time will tell. I think historically you're right, but I'm hoping that it's shifting. I don't know if some people may like hate philanthropy and not see those shifts, but I see some hope on the horizon.
I agree.
It made me think a little bit like when Monica and I were talking a little bit earlier about, is this a good time or, a bad time regarding equity and justice in the country? We've made advances and now there's pushback against DEIJ and whatnot. But people tell me, well, in some ways, this is the playbook, and this is what happens in our history. When there's advancement and there's pushback, there's a little bit of retrenchment, and then you keep on moving ahead. I do think like this issue of health equity is here, that again, compared to even 4 or 5 years ago, and along a broad variety of audiences, it's here, right? And so I still overall feel that the arc is bending in the right direction.
To me, the commitment to health equity feels a little bit like in global health, the commitment to human rights or health as a human right. It feels not directly legally enforceable, but a tremendously valuable flag in the ground, and something that you can use because everyone is so rhetorically committed. You can at least use it to say, you say you're committed to health equity. If that is true, then these things. And it's not perfect. Obviously, we might all wish that there were different kinds of enforcement mechanisms around healthcare delivery organizations living up to a rhetorical commitment to health equity, but at least it gives you something to wrestle with, an accountability mechanism, such that I now think about framing a lot of my research as saying, if you are committed to health equity, then this is the gauntlet in front of you. And if you don't meet the gauntlet, then I'm going to call you a hypocrite in the rhetorical commitments you make to health equity.
I will say that Monica, this is where I feel like the work that we did on the review is actually quite relevant, because one of the fundamental, rationales that we hear, the sort of base rationale that we hear for addressing social risks and assets and needs in the healthcare sector has been an improvement in racial health equity. I mean, it's like part and parcel of the argument that people are using for doing this work or investing in this work. And yet very little of the research has actually explicitly looked at health equity outcomes. And Monica's work, I feel like, is testament to that. Let's hold ourselves accountable.
Does anyone have a burning last word? If not, I'm going to turn it back over to Charlotte. This has been such a delight.
Really, really fun. Thank you so much.
Thank you, Lauren and team.
Charlotte, take it away. Thanks, guys.
Thank you, Lauren and everyone. Honestly, I don't think anyone on this Zoom wants this discussion to end. Many thanks to our panel, Monica, Marshall, Laura, Lauren, for such a thought-provoking and informative conversation. At the same time, specific and wide-ranging, clarifying and challenging. So much food for thought. Also, thanks to the audience members for joining us and contributing your own very helpful thoughts and questions, very stimulating there as well. If you'd like to revisit this program, look out for the video recording, which is going to be posted on the center's YouTube channel, probably in a few weeks' time. Looking ahead, just very quickly to remind you that on April 26th, we'll take up the related topic of market medicine, how money is changing the experience of medicine and what practitioners and organizations can do about it. Please come and join us if you can. And with that, we're ready to adjourn.